We have swapped our lectures a bit, so that you can actually hear the introduction to the artificial iris from me, so to speak, and I want to show you why this is actually something special for the patient. That's actually one thing that can help many patients. Human optics has made me rich, I have to show that. But in the end, it is about such patients who have suffered such serious injuries. When they open their eyes, it looks very wild at first. Yes, in the ultrasound, you can usually see that in these injured eyes, a lot is happening in the background, and then you stand there in the operating room and look dumb, out of your sterile gown. And with such findings, you often just wish for a new eye.
These new eyes, they don't exist yet.
But we can do a lot nowadays to reconstruct such eyes. And if you look at such a statistic with traumatized eyes, then a very large part is first of all caused by trauma. And many of these iris defects that patients have in the course of the disease are trauma-related. So that's the main cause. Congenital aniridia, for example, is a rarity of these. So we are moving in the field of reconstructions. And the main problem of these patients who have such iris injuries is clearly glare. If you ask the patients on a scale of 1 to 10, the glare complaints are somewhere between 8 and 10. So that's really the main problem that these patients have. And of course, there are several ways to fix this. Of course, you can just cover the eye. Yes, then the glare is gone. Patient is happy or is putting on sunglasses. That's also a possibility. This is one of the conservative measures to treat this glare. You can also put on a baseball cap. But he's doing something wrong. You just have to carry them around properly. These are the possibilities you have to take action against this glare. In the case of minor injuries, you can also sew these rest out the iris together again through iris sutures and reconstruct the pupil again. You can't forget that. However, this only works for minor defects, such as up to about 2 hours. With a traumatic dilated pupil, which also occurs occasionally, sometimes as part of cataract surgery, there is the possibility of collecting the pupillary hem with a suture, placing a ring and tightening this knot that is formed in the eye so that the pupil becomes smaller again. So just like when you pull a handbag or a tobacco pouch together by the seam or ribbon, you can adjust how big the pupil should be. And with that, you can actually also achieve very good cosmetic and aesthetic and functional results for the patients. But the supreme discipline is when they manage to restore a patient in such a way that you cannot tell which eye was the injured person. And if you see such a patient here, I would have to ask you, which eye is the injured eye? Which was the one where the iris is injured? Then it is very difficult for them. There was shown right eye, I heard, also right eye. But look, the left eye was the one where there was no iris and no lens in the eye. And to produce such results, that is of course the goal of what you have, and also the possibilities you have today. These traumatic iris defects can also be treated relatively well with an iris print contact lens, as in this patient picture. This usually looks good at the beginning if you look straight at the eye. And if you look at it from the side, you can see that it somehow looks artificial. Many patients do not tolerate contact lenses after such injuries. And then, of course, you can also use an intraocular implant, where the patient has had an operation once and then hopefully has no more problems for the rest of his life. And then you also have correspondingly good aesthetic results. How do you do that? So there are ways to make implants with iris segment rings. Some of them no longer exist. Yes, some of them are no longer produced. There are lens implants where an attempt has been made to make them individually after they have been printed. These no longer exist either. Nowadays are also relatively associated with large incisions to get this implant into the eye. The implant from Reber here made of silicone, which is no longer available due to discrepancies with the Russian region, so you can no longer import. And of course, you can also insert other types of special lenses into the eye. However, Human Optics has had the artificial iris, which he has already seen in the films earlier in various variations, on the market for some time, and this is a very good product, because they can also apply it very individually in order to achieve these corresponding surgical results. To achieve such results, the first thing you need is an iris. You order them and you actually need some kind of intraocular lens. And that's the beauty of it. You can actually take any lens that you have in your repertoire, in your operating room, in your closet. Techniques are now a dime a dozen. Yes, I once did a series about 6 different surgical techniques. You've just heard 3 more techniques from Dr. Aman. So there is for everyone who can let off steam, depending on how much time, leisure, and desire he has, to spend in the operating room to bring this implant into the eye. I can actually only concentrate on 2 surgical techniques, namely the technique where the implant is implanted directly into the capsular bag with the artificial lens during cataract surgery, and the other is where the implant is inserted into the eye with an iris in a whopper or sandwich, so to speak, and then sewn there. The combined surgery ultimately takes place in such a way that the iris and lens can be sewn separately to the sclera, or the iris, and lens can be taken together, and then only the iris can be sewn to the sclera. These are the 2 most common techniques that can be performed for total aniridia. You can also fix the iris and lens in such a way that you can attach them to the sclera with a Yamane technique by mushrooming. So these are the possibilities that have been published in the meantime. If you are planning cataract surgery for traumatic mydriasis, like in this eye, then it is a good idea to insert not only the lens into the capsular bag in this one step, but also an iris implant. This causes the least trouble because this implant is far away from the rest of the iris. This is built into the capsular bag, and thus causes significantly fewer problems than if you use other techniques. Ultimately, you do a normal cataract operation with a perhaps slightly larger rhexis. Remove the lens, remove the cortex, implant the lens of its kind without making a special biometric change, and in this case I have inserted a capsular tension ring to stop the capsular bag accordingly. And when these 2 implants in the eye are inside the capsular bag, the iris is taken out of the pack, trepanned to the capsular bag diameter. This is a challenge because they would then have to know what the capsule bag diameter is. The diameter is 9 to 9.5 millimeters, then rolled with tweezers. It's like rolling up a pancake. And when you have done this roll, you have to put it into an injector with which you can also implant a lens. So you take this roll, so to speak, a normal injector, push it in there, and then it is implanted in the capsular bag like a lens. And you have to make sure that it is lying the right way around, that it unfolds in the capsular bag, otherwise you have difficulties and have sulcus implantation, which theoretically also works, but it is a little smaller trepanned. And when you have unfolded it in the capsular bag, and the nice amount of viscoelastic to protect the cornea, you suction it off, and you actually have a triple implant in the capsular bag afterwards, and it works well, because the sum of the capsular tension ring, lens and iris is still smaller than your own lens, so there are no space problems in the capsule bag. Of course, you can also make the whole thing a little more difficult with this patient. She had received cataract surgery on one eye without any problems with a multifocal lens, and the second eye, a few weeks later, had a capsular rupture with complications. Vitreous prolapse iris defective due to the phacotype, which then ate up the iris, and patient is now aphac with a dilated pupil and totally unhappy, and would actually like to see better again, have a Mutigo lens, and have less glare again. These are the jokes you have, and you can do something like that. You can implant an artificial lens with an artificial iris in such an aphid eye. And in this case, due to the patient's request, I decided to bring a multifocal lens closer to the back of the artificial iris. Of course, look backwards to ensure that the artificial lens is well centered in the center of the pupil. The rings, you can see it very nicely here,
Has been a good centering.
You don't need the haptics that are there at the edge in this case, you simply cut them off. Now you have a self-made implant, so to speak. Now a medical device manufacturer, and you then sew this iris with 9.0 Prolene threads at the edge. Then you lead out through the scleral tunnel to the right and left, with the help of, for example, great tweezers, who now have it, or just with retrieval needles, grasp the implant and then implant it under plenty of viscoelastic protection. I always do sclerocorneal tunnels to keep astigmatism as low as possible. The threads then pull into the eye to the right and left when you have placed everything well. A very good centering, and the position of the lens and the iris is actually such that you don't have to take any special calculation factors into account in biometrics. So this position usually sits very well, and this patient was actually very happy in that she managed 0.8 SC and has significantly less glare. That's what you can achieve. Even in somewhat more complex initial situations, it is important to know that subjective glare decreases significantly and very significantly in almost all patients. That is the main goal we have with such an implantation. And at the same time, we also have a beautiful aesthetic result. You have to keep that in mind. It is made individually. This iris according to the partner's eye. There were still last year when it was still gender non-specific, no, specifically presented. There is a nice overview article in Der Ophthalmologe, where you can download it as a PDF open access. These are the results and surgical techniques summarized. Ultimately, I can tell you that the implant naturally offers significant possibilities for traumatized eyes, makes pronounced better glare reduction, makes good cosmetic results, but is not a standard operation. That's something special. You don't do this every day. If I do that once a month, that's a lot for me. You need a learning curve. This not everything is fine and dandy with the first operation. It can also cause problems. You have to know that. You need a surgeon who can handle the anterior and posterior segments. Surgical aftercare is relatively straightforward, as with any other type of secondary lens implantation. You also have to pay attention to the cornea, to the eye pressure,